Good afternoon, everyone. I think we've just hit afternoon. And thank you to the conference organizers for the opportunity to present this work. So each year, about 1.2 million children are born to mothers living with HIV. Due to the success of prevention of vertical transmission programs, around 90% of these children do not acquire HIV. So children HIV-exposed but uninfected, or CHEU, represent a growing global population with an estimated 16.1 million children worldwide. Compared to children HIV-unexposed uninfected, or CHUU, exposed children may be at risk of a range of adverse health outcomes, including preterm birth, low birth weight, increased morbidity and mortality, and poorer growth and development. Some of these disparities in morbidity and mortality may be due to differences in perinatal and maternal factors, such as higher rates of preterm delivery and low birth weight, suboptimal breastfeeding and vaccination, and poor maternal health. However, even after accounting for these factors, differences in health outcomes persist, and the underlying reasons remain unclear. Despite some inconsistencies, the majority of available evidence suggests that exposed children are at increased risk of infectious morbidity and hospitalization compared to unexposed children, particularly during infancy. However, data on the risks beyond infancy remain limited. So to contribute to this limited body of evidence, we aim to assess whether infectious cause hospitalization rates from age 1 to 5 years differed between exposed and unexposed children in a South African birth cohort. For the study, we enrolled 991 pregnant women with and without HIV from a large primary healthcare facility in a lower income area called Gugulethu in Cape Town, in South Africa. After delivery, women and their infants were prospectively followed up for 12 months, including assessments at up to 4 postnatal visits. Province-wide hospitalizations were tracked against unique health identifiers, enabling electronic identification of all public sector hospitalizations within the province. We have previously described the neonatal and the 1 to 12-month hospitalization outcomes in the cohort. A key finding was increased infectious cause admissions in the exposed group, with nearly 3 times higher rates between the age of 1 and 12 months. In this further analysis, we studied hospitalizations from age 1 to 5 years. Reasons for admission were derived from electronic ICD-10 codes, which were captured by provincial hospitals, and we categorized these as due to infectious causes versus other causes. This flowchart shows the enrollment and follow-up of pregnant women and their children in our cohort study, stratified by maternal HIV status. After accounting for pregnancy losses, loss to follow-up, neonatal and infant deaths, and HIV diagnoses, 446 exposed and 455 unexposed children were included in this current analysis. In total, 147 admissions occurred from age 1 to 5 years, with infectious causes accounting for 59% of all admissions. The figure on the left shows the total number of all-cause admissions since birth, shown by age in months, and on the right are the infectious cause admissions. All-cause admissions from age 1 to 5 years occurred in 9.2% of exposed children, shown in red, and 10.8% of unexposed children, shown in blue, whereas infectious cause admissions occurred in 6.5% of exposed and 7.5% of unexposed children. We can see that the number of hospitalizations decreased with older age for both groups. And if we focus on the right, we can see that the number of infectious cause admissions per month was noticeably and consistently higher from age 1 to 11 months among exposed children in red compared to unexposed children in blue. But from the age of 12 months, where there's a black bar, the admission numbers became lower in both groups and were relatively comparable thereafter. the crude incidence rates for infectious cause admissions from age 1 to 11 months was more than double for exposed children, whereas from age 1 to 5 years, it was the same for both groups at 2.4 per 100 child years. We used random effects Poisson regression models to calculate adjusted incident rate ratios for infectious cause hospitalization among exposed versus unexposed children. We adjusted for potential confounders and clustered by child, as a child who was previously hospitalized may be more likely to be admitted again due to underlying vulnerability. And as in our previous analysis, we adjusted for child sex, infant vaccination status at 12 months, maternal education and type of housing at enrollment, and maternal age at delivery. Our results with an adjusted IRR of 0.7 showed no evidence of increased hospitalization rates among exposed compared to unexposed children from the age of 1 to 5 years. Breastfeeding duration during infancy and preterm delivery were evaluated as potential mediators in a separate model, and breastfeeding duration was no longer associated with reduced rates of admission after the age of 1, whereas preterm birth still showed a trend towards increased admission rates after infancy. Between the age of 1 and 5 years, only one child with HIV exposure died at age 13 months, although our mortality data is restricted to in-facility deaths and may be incomplete. Maternal mortality was more than 3 times higher among mothers with HIV, with 2.5% having died compared to 0.7% of mothers without HIV. So how do our findings compare with those of other studies? Few studies from sub-Saharan Africa have examined infectious morbidity and hospitalization among exposed versus unexposed children beyond infancy, with mostly similarly reassuring findings. Studies from South Africa and Uganda showed increased rates of infectious morbidity during infancy, but no difference after 12 months. A hospital-based study in Uganda, Kenya, and Malawi found that exposed children under 2 years of age had increased risk of in-hospital mortality, post-discharge mortality, and prolonged hospital stays, although the outcomes were not stratified by infancy versus over 1 year. 2 studies from high-income countries, Denmark and Canada, have likewise reported no significant differences in hospitalization beyond infancy. So I'd like to draw your attention to the numbers in red, which show similar rate ratios to ours of 0.7, and also highlight the relatively small sample sizes. So our original sample size was designed to detect differences in infectious cause admissions during the first year of life, based on an anticipated admission rate of 10% in unexposed children and an absolute difference of more than 5% in exposed children. And under those assumptions, enrolling 400 infants per group had provided sufficient power. However, from the age of 1 to 5 years, admission rates were much lower overall, only 6.5% in exposed compared to 7.5% in unexposed children, and the difference between groups was smaller. So to detect a 2% difference in admission rates with 80% power, we would have needed more than 2,000 children per group. And to detect an even smaller 1% difference, such as what we found, more than 8,000 children per group would be needed for sufficient power. So our study with 446 exposed children was adequately powered to detect the large differences that we saw during infancy, but was underpowered to detect smaller differences in hospitalization rates in older children. A key limitation of all existing studies reporting on hospitalization outcomes among exposed versus unexposed children beyond infancy is this relatively small sample size, which has ranged from only 159 to 726 exposed children. Larger, more adequately powered studies are needed to more definitively evaluate infectious morbidity risks beyond infancy. And the good news is, look out for a not yet published analysis by one of my colleagues, Shani de Beer, and she looked at an appropriately large province-wide cohort of exposed versus unexposed children in South Africa, and reassuringly found that despite higher infectious cause admission rates in infancy, exposed children from 23 to 36 months did not have increased rates. So in conclusion, the elevated vulnerability for infectious morbidity among exposed children does not appear to persist beyond the first year of life. And these findings highlight infancy as the important window for targeted interventions, while offering reassurance about the longer-term infectious morbidity risk in this population. And our study also shows the value of strengthening routine health data systems to enable studying outcomes such as these. I'd like to acknowledge the children included in the study, their mothers, clinicians, and service providers, and thank my co-authors, and I have no idea whether I'm meant to be thanking funders or not, because our research unit has not received any renewal of our funding. Thank you.